All right, we are so happy to have Dr. Virgil Dalm here again. He's been with us for many, many years now. But Dr. Virgil Dalm is an internist, clinical immunologist working, how do you say it? Erasmus MC Rotterdam in the Netherlands, where he's the head of Department of Allergy and Clinical Immunology and of the Primary Immunodeficiency Center. His clinical and research work focuses on both inborn errors of immunity, rare diseases in his immunological work in the field of 11q disorders. The International Union of Immunological Societies acknowledged 11q disorders as an IUI. So Dr. Dalm has been working with us for many, many years, and so we are thrilled to have him with us again this year. So let's give him a warm welcome. That?
Yeah, I think it's a combination. Yeah. Okay, well, thank you. Maybe it's a bit loud. Well, thank you for the invitation. Thank you for the nice introduction. And indeed, like Liz introduced, I'm a clinical immunologist from Rotterdam, the Netherlands. But more importantly, I'm a father of these two kids because just to tell you some personal, these are my two kids. My daughter on the left side, she wants to become a forensic doctor. I don't know why, but that's her dream. So she is doing already some rotations in our institute. And my son has a better goal. He wants to become a professional football player for the Dutch team. And we definitely need that, yeah. So today I'm going to talk about the immunological consequences of 11q disorders. So I want to give a brief interview on the immune system. Why do we need an immune system? What is it? And what goes wrong in many of the people with an 11q disorder? I have to stand a bit still because of the camera. I'm used to walk around a lot, but I will try to keep, if I'm moving too much, please let me know. Because I was watching a movie yesterday in the plane about Elvis Presley. I don't know whether you saw the movie. Really nice. And he also couldn't sing without standing still. So I think I'm in a good surroundings. But anyway, to be a bit more serious, we're going to talk about the immune system. Why do we need the immune system? Well, this is a nice situation. If you live here, very clean air, very clean areas, nice air, no pollution, so not a lot of germs to get in touch with. But unfortunately, our life is a bit different. So we get in touch with a lot of bacteria, viruses, fungal infections all the time. As we are sitting here, as we are in a hospital, or in our outdoors. And this is, of course, a very bad situation. If you're working in these kind of conditions, you are exposed to a lot of bacterial, viral, fungal infections. And to fight these infections, or to prevent you from getting sick, we need our immune system. And actually, our immune system is what I always call a shield to the outside world, like shown over here. So what does it do? It prevents us from getting sick, or prevents us from getting very sick from infectious complications. And of course, it's not that easy like an umbrella, but our immune system consists of a lot of cells, proteins, antibodies, and all kinds of stuff that all together builds our immune system. I don't want you to remember this, but just remember that the immune system is composed of many compounds, cells, antibodies, I just heard proteins in the previous talk, but these are all forming our immune system. And all these cells and all these parts of the immune system have their own function. So for instance, B cells, depicted over here, which is very important for the rest of the presentation. So that is something to keep in mind. B cells produce antibodies. And you may have heard a lot about antibodies, of course, during the COVID pandemic, because we were all concerned, do we have enough antibodies after vaccination? Are we prevented from serious infections after vaccination? It all had to do with building memory in the immune system, building antibodies. But this picture just is here to show that all cells and all parts of the immune system have a specific role. So B cells and antibodies are particularly important for preventing bacteria. While, for instance, neutrophils over here are very simple immune cells that are just there eating incoming agents, for instance, bacteria as well. So the left part of the immune system is the rapid part. If you get infected by bacteria, these neutrophils come into action. They can eat the bacteria, so they can get rid of the bacteria from the body. But the right part of the immune system is the very important part that builds up memory. So it's important in vaccination. It's also important in preventing repeated infections, as you may recognize in your kids, for instance. Because this right part, yes, you can have an infection. Neutrophils clearly infection, but the right part should come into action to build up immunological memory to prevent you from getting sick again from the same bacteria. And what we see in patients with problems in the immune system, they get sick over and over again from the same bacteria, from the same site as the lungs, because the building of memory is disturbed. So that's in a brief the immune system with all cells. For instance, the T cells are more important for clearance of viral infections. So what are the immune cells? This is also Ken Paris, my brother in crime. I always try to present here with him together, but unfortunately over the past years we were not able to. But he always described the immune system as a little army. So we have soldiers, B cells, T cells, neutrophils. Together they build an army to fight infections. And this is the perfect situation. So if the immune system works well, your body is in balance. The immune system is in balance, and then you have what we always say, no infections on the left. It's of course not completely true, because also if you have a normal immune system, you can get the colds, you can get the fever, you can have infections, but not too much, not too severe, not too many, but generally low number of infections. And of course, also the immune system is important in preventing autoimmune disease, because if your immune system gets overactive, you can have autoimmune disease. Think of rheumatoid arthritis, think of diabetes mellitus, type 1. So generally, if the immune system is well balanced, not too many infections and no autoimmune disease. But what happens if something goes wrong? So look at this picture. So what we see is holes in the umbrella. And I think this nicely reflects the defects in immune deficiencies. So depending on where the hole in the umbrella is, you have specific conditions. Like I just said, B cells, antibody production, fighting bacteria. If there's a hole in the B cells, you have an increased risk of bacteria. If you have a defect in T cells, for instance, you have an increased risk of viral infections. So always when we see patients with immune deficiencies, we have to think, where is the problem? What kind of infections do we see? And in which cell type or which cells the problem should be. And this is what happens. So when the immune system is not working well, so the balance is not well controlled, we call it an immunodeficiency, because on the left you have lower levels of antibodies, lower numbers of immune cells, so no protection against infections. We call it an immunodeficiency. And on the other hand, if the immune system is overactive, you get autoimmune disease. So these are 5 examples of common autoimmune diseases. Some of them you may have heard of, but there are a lot. So actually there are a lot more autoimmune diseases than immune deficiencies. So immune deficiencies in general are very rare. So there's also the difficulty in your families that people tend not to recognize immune deficiencies because these are so rare and many doctors don't think of it. So that and autoimmune diseases are very well known. Rheumatoid arthritis, everyone knows it. Diabetes, everyone knows it. So it's not difficult to make a diagnosis, but for immune deficiencies, it's more complicated, and you may or may not have experienced that in your case. So going back to immune deficiency. So what if something goes wrong? Now, well, I already told you that if something goes wrong in the immune system, you have an increased risk of infection. That's the first part I want to focus on for today. And also again, every time we have to think, what is our immune system built on? Where is the problem? What kind of infections do I see? Where do I have to look if I want to think about a diagnosis? So what is the shield made of? So to better understand that, I think I want you to better understand the immune system, because most of the doctors you see, you have to teach them as well, right? Because they don't think about these deficiencies. And it's not to be rude, but it's just because it's rare. And they don't really know what's going on because they are not thinking about immune disorders, is my opinion over the past years. So I will present some slides later on. I think well, the slides will be shared, and I think it may contain some important information to ask your doctors, please perform these tests in my kids, because those are very helpful. Those are not expensive, so it's not a reason not to do it, I would say. And I think it's really important to get the immune system tested. So the first part of the immune system. So remember the picture, lower left. Those were the, let's say, not so smart immune cells. They just recognize bacteria. They do not belong here, and then these get rid. These bacteria are removed by these cells. So this is a neutrophil. I always like this picture to show to students because this is a neutrophil chasing bacteria. The black moving things are small bacteria, and the neutrophil is trying to catch the bacteria. That's the first response when the bacteria enters the bloodstream. And as you see here, it keeps changing, and eventually it engulfs the bacteria and it kills the bacteria. So that's where your immune system starts. But now, when I get an infection now, for instance, I have a scratch in my arm, bacteria enters my bloodstream, neutrophils tries to catch this bacteria. In all people with 11q disorders, these functions do work properly. So generally, the initial removal of a bacteria is not a problem. So this works. But the more important part, presented on the right part of the screen, is what we call the memory part of the immune system. The bacteria gets removed, but normally the immune system should be activated to produce memory. So in case a second hit, 3 months, 6 months later, few years later, the immune system remembers, hey, that bacteria, I've seen that before, and I should get rid of it immediately, because that prevents us from getting sick over and over again. And there's something that goes potentially wrong in 11q disorders. So which cells are important? T cells and B cells. Remember it, because you should ask your doctor to test for them. And I put it on paper later. So T lymphocytes, those are very important for clearance of viral infections and fungal infections. Fungal infections of the skin, mouth, the gastrointestinal tract, for instance, and any kind of viral infections. The B lymphocytes, those are very important cells because these produce antibodies. Like I already said, antibodies are very important in clearing bacterial infections, also in clearing viral infections, but mainly responsible for fighting bacterial infections. And these antibodies look like this. And why do they look like that? Because what they do, they recognize bacteria. So here you see the antibodies, and those are recognizing specific bacteria, and they are going to catch these bacteria, and then eventually bacteria get killed. I'll try to show this video. So this is the bloodstream again. So blood cells, white blood cells, red blood cells, all kinds of blood cells entering or floating around in the bloodstream. And then there is this bacteria. And you see the bacteria has some specific forms. And then these antibodies on other cells can recognize the bacteria by these antibodies, and these bacteria got catched by these immune cells and these antibodies circulating in the blood. And then these bacteria who are catched by antibodies are recognized by these eating cells that you see that I saw before, and then these bacteria get indeed removed. So these antibodies Very important because those are floating around. If an antibody recognizes specific bacteria, it catches it, and then these neutrophils, those eating cells, eat the bacteria plus the antibody. So the antibodies are very important for prevent repeated infections. So this is what happens. It looks very complicated. It's quite simple. So if you get your first encounter with the bacteria, antibodies are formed, can be an infection, can be vaccination. You induce antibodies, these will go down again with your memory cells, your B cells. When you get a second infection, these B cells think, well, I got this infection before, I recognize this bacteria, and they instantly start producing large amounts of antibodies. So vaccination, for instance, is a priming of the immune system. It starts antibody formation, builds up memory. So in case of a second hit, you see the number of antibodies is much higher. So it's a rapid response after a second encounter with the same bacteria. And the immune system, or antibodies, or immune cells, are produced in many organs. For instance, in the bone marrow, there is the start of the production of immune cells, but also the liver, the thymus, tonsils, lymph nodes that we all have are all very important in building up this immune system. So I'm a clinical immunologist, like already said by Lindsay, and I see patients with different compositions of roles in this umbrella. The different combinations. Some people have a defect in the neutrophils, eating cells. Some people have defect in the B cells, some in the T cells, and some in combinations thereof. Most of the patients that I see are patients with antibody deficiencies, and this is just to show how rare these disorders are. Because if I look at my outpatient clinics, this is a study performed in the Netherlands, but it's actually the same in the whole world. So 2/3 of all patients that we see with an immunodeficiency have an antibody deficiency. So 60 to 70% of the patients that are in my room have a difficulty or problem in producing antibodies. How many of these patients do we see? 1 in every 25,000 people. So very, very rare. We are a small country, 80 million people, and only 3,000 patients that we see or that we know in the Netherlands. So it's ultra rare, and it's therefore difficult to recognize for physicians that are not used to seeing these patients. But most of the patients we see are antibody deficiency patients, and this is 2/3 of all. But of course, the defect can be anywhere in this immune system, also problems in the T cells, but those are much more rarer. And I think also for this presentation, it's important to talk a bit more about antibody deficiencies, because that's the most important group with respect of numbers, and also I think one of the most important issues in 11q disorders. So just to take a sidestep, patients that I see have patients with what we call X-linked agammaglobulinemia. Those are boys, genetic defect on the X chromosome, and they don't produce B cells, and they don't produce antibodies. So if you look at their blood, they have 0 antibodies. So these kids, these guys, because that's only a disease seen in boys, they have very severe infections, sinusitis, otitis, pneumonia, since birth or really early childhood, because they cannot form antibodies. So they get repetitive infections, repetitive pneumonia, bacterial infections, and it's a very severe condition. On the other hand, in green, those are healthy individuals. These produce B cells, these produce antibodies, and they don't have many or severe infections. And there's a group in the middle from less severe to more severe decrease in antibody production and antibody function. But all of these people, when you are in the red area or in the yellow one, have a problem in B cells, antibody formation, and have infections. And what kind of infections do we see? Infections, gastrointestinal tract, ENT, and lung infections. Those are the most important infections that we see, and we have to think, could it be an antibody problem? So these are typically young people, because those are inborn genetic problems. So most of the patients that we see start having infections in early childhood, and specifically otitis, sinusitis, lung infections, but also gastrointestinal tract infections with diarrhea, loss of weight, loss of appetite. So if you recognize any of these conditions, recurrent infections, respiratory tract, gastrointestinal tract, in 11q disorder, you should think, could it be an immunodeficiency? Not every patient or not every person with 11q disorder has an immunodeficiency, but I would say over 90% of the patients that we have seen over the past years, and I'm talking for myself only, also other colleagues that I see, over 90% of 11q disorders have a mild or severe immunodeficiency. Also, the severity can change between individuals, of course. So what do we see? Infections, ENT, lung, gastrointestinal tract infections, but also skin abscesses, osteomyelitis, so very severe organ infections. What are the most important problems? Lower levels of immunoglobulins, less production of IgG, immunoglobulin G, and also decrease in function. And that's also very important to remember, because we are doctors, we like numbers, but numbers don't tell you all. Because some people have normal production of immunoglobulins. So if you measure blood, then antibodies are all normal. But if they do not function as they should, of course, you can still have a problem. So not only measuring, but also evaluating function. Very important. So how did I end up here? Because I was a clinical immunologist, I was seeing a lot of patients with ultra-rare inborn errors in immunity, but I had never seen patients with 11q disorder until I met this kid who unfortunately passed away a few years ago, who was a guy from the Netherlands, and who was referred to my outpatient clinics. I think at that time he was around 18 years of age. He was known in pediatric hospital because of the Jacobson syndrome, and he was referred. I don't know whether you can see it well on the screen, but his hands were full of warts, and his feet as well. But I only show you the hand picture. So this was an adult patient with multiple warts, and this is not normal. Kids can have warts. Kids can have multiple warts on the hands, but normally when your immune system builds up over time, this virus, human papillomavirus infection, gets well controlled by T cells. So when kids are little, they can have warts, but over time the immune system gets better and T cells depress viral activity. So this rose my attention because this, I thought, an adult patient or an adult man in this case, with this multiple warts, there should be something wrong. And then I saw a picture, or actually a scan of his lungs, and this is a normal lung tissue. A normal lung should be black because that's air. And you see on this right lung, because this is the right lung, this is the left lung, it's the other way around, and we can see it. And the right lung, you see this. This is very severe pneumonia. This was a scan 3 years before I met him for the first time. So he had already had a very severe pneumonia once, and it was thought, well, this guy has some problems with swallowing, so probably he had eaten something and it came in his lungs and he got a pneumonia from that. So it was not really paid attention to. It was just called bad luck at that time. But this combination rose my attention. I thought, well, there should be something wrong with the immune system because so many warts, a severe lung infection, there should be something ongoing. But for the first time, it was that I saw a patient with an 11q disorder and these infections. So I thought, is there some link between this? And of course, I was looking in literature, and when you look for Jacobs syndrome, you always find this name of Dr. Grosbach, because he already had shown before that indeed in a number of patients, so over here there were 78 patients, so I'm just looking at the infections now, there was in the majority of patients, so over 50% of patients described, there were recurrent infections. So yes, it seemed that already there was some evidence that infectious problems were part of the clinical phenotype of people with Jacobson syndrome. And when you look in literature, because that's what we do, we try to find new information and try to find links. There were some cases all around the world that described people with Q disorder or Jacobson syndrome with immunodeficiencies. So this is a case with antibody deficiency, a case with B and T cell problems. Also here, a French patient with all one-on-one patients. So there were some signs. So this is not new because this was already published more than 10 years ago. So there was the link between immunodeficiency and 11q disorders. So we tried to set up a small study in the Netherlands. We invited a few patients with Jacobson syndrome to test their immune cell function because it's all well. If this is already described in a large number of patients, so they have infections, also in the number of patients throughout the world, it has been described association between 11q disorder and immune deficiency. Would it indeed be something that we could explain as well? So these were 6 patients that we were able to test. Those were from kids to adult patients, the oldest being 35 years of age. And most of them, so 5 out of 6 had a deletion for part of the long arm of chromosome 11, and 1 patient had a triplication. So it's not Jacobson, but it's 11q disorder more generally. And if you look in these patients, 1 of them, no infections. So again, not for everyone has an immunodeficiency, but most of them suffered from recurrent otitis, sinusitis, pneumoniae, the infections that I just mentioned. And we tested their immune cell function. So we tested for antibodies because these patients mainly suffered from ENT infections, lung infections. So we thought, hey, the problem should be in the B cell, could be in the antibodies. And if you look in all patients, IgG, antibody levels, total antibodies, those were expressed over here. So all of them had low levels because the level should be above 7. All but 1. So the patient that didn't have infections also had normal antibodies. But the other 5 with infections, indeed, all had low to very low antibody levels. But more importantly, we also tested immune function. So what we do, we vaccinate patients to see whether they are able to produce antibodies, to see whether the immune system is able to produce antibodies after vaccination. And also here, that's what we measure with pneumococcal vaccination. All 5 patients with low antibodies, they also had a disturbed function of these antibodies. Again, it's total level of immunoglobulins, but more importantly, in my opinion, is the function of these antibodies. So it should be involved in evaluation. So that was in 2015. So we published that in 2015, and why that's important, I will come back to that a bit later. So what did we find? Found lowered production of antibodies and disturbed function of these antibodies. These antibodies are produced by B cells. So the question was, if these patients produce lower levels of antibodies, if these antibodies do not function well, is there a problem in the B cells? Because this is the cell that produces antibodies. These are B cells. So B cells are important in producing antibodies. I just told you. So these B cells produce antibodies. Those antibodies start chasing bacteria to fight them. But what these B cells do when they get activated, they produce antibodies to fight an infection. But the B cells also start forming what we call memory B cells. Like I just presented, these memory B cells, these are generally very low, but after an infection, after a vaccination, these memory B cells increase. This is your memory, immunological memory. So in case you get this infection again, these memory B cells start producing antibodies much quicker. So this is your immunological memory. So the B cells are very important because they are, well, just swimming around in your blood or in your lymph nodes. But once you get an infection, these memory B cells can directly start producing these antibodies. So after an infection, building up memory is really important. So we started looking, is there something wrong in these cells? So what do? We look for the B cells in Jacobson syndrome patients. Well, these are control levels, so these are healthy controls. And this is the normal mean number of B cells in control patients. And what we found in those 6 patients with Jacobson syndrome, that the number of B cells was slightly lower than in the healthy population. But also here, you see, these are healthy individuals. These are Jacobson syndrome patients. B cells in general, in mean, are a bit lower, but you see some of those have comparable numbers than as compared to healthy controls. So the number can be lower, but is not lower in all patients. So B cells, yes, of interest, but we couldn't say too much about it. But this is more important, because if we look as a the part of B cells, we look at the memory B cells, then it's very obvious that the 6 people with Jacobs syndrome are extremely low in the memory B cells. This is, again, patient 2. You remember, the patient produced antibodies, that the function of antibodies were normal, but still very low memory B cells. So the question is it truly a normal immune system, or is it still a bit a weak immune system? But I think very important that indeed, again here, not just looking at simple numbers of B cells, but you have to get more detail on the memory B cells, because that's where the problem is. So we concluded, yes, there's definitely an antibody deficiency in patients with Jacobs syndrome, because those were the patients that we studied. And I think it confirms the findings of Paul that indeed the majority of patients suffer from recurrent infections. So what did we see? And I think this is important to remember. Most of the patients have lower production of antibodies. So the antibody levels in the bloodstream are low. Immunoglobulins, IgG, the function is diminished. You have to measure it because it's important to measure function by vaccination, and especially the memory B cells are low. But just measuring B cells alone, that's not enough. You have to measure memory B cells. And what do we see? Recurrent infections, and especially of the respiratory tract. And I just told you that it's quite difficult to recognize immunodeficiencies because you have to think of it, because it's very rare. But based on the studies that we did, I think it's quite interesting that you have the IUIS, that's the International Union of Immunological Societies, that describes all kinds of immunodeficiency. It has recognized 11q disorder since a few years as a primary immunodeficiency. So it's now well known and well recognized, well established that indeed patients with 11q disorder have an immunodeficiency. Of course, not all, but it's now more and more in common knowledge that if we think about patients with 11q disorder, it is recognized by this international union as a primary immunodeficiency. So I think it's also very important that you can show to your doctor, say, well, maybe you may not be aware of it, but indeed it's internationally well recognized that an immunodeficiency could be part of the clinical picture, and you should potentially test it. So, how to diagnose? Because that's an issue that we need to address briefly, and I think it all starts with think of it. Because if we don't think of it, you'd never do the diagnostics properly, and you can never find an immunodeficiency. So when do you need to think of it? And maybe you can also look at your kids. These are warning signs. because internationally we use these warning signs, which could be triggers to think of an underlying immunodeficiency. So these are for adults, but the same are for children. An increased number of infections, inability to grow properly, severe infections, difficulty in treating infections. Your kids may require multiple courses of antibiotics and still do not recover. These are all things to keep in mind when thinking about could there be an immunodeficiency. So that's of course the start. Is there indeed increased risk of infections? Do we see multiple difficult to treat infections? What is wrong? And then immunological evaluation. This is basic. Immunoglobulin levels, IgG, IgA, IgM, those are the antibodies produced by these B cells, and IgG is most important because that IgG is your memory immunoglobulin produced by these memory B cells. So if you start testing, it costs around $10, you have IgG, IgA, and IgM. It's very important, you also have to evaluate the function of these antibodies, and then we do by vaccination. So what we do, we measure antibodies, we give a vaccine, most of the time it's a pneumococcal vaccine, and what you expect is after 4 to 6 weeks, you see an increase, as shown over here, in the antibodies after vaccination. And what typically occurs in patients with antibody deficiencies, that there is no response or very mild response, as depicted over here. So then pre and post vaccination, there's not an increase in antibodies or not an adequate increase in antibodies. That should be part of testing because it tells you about the antibody function. So this is what we need to do. Immunoglobulins, we test for the total levels of white blood cells, B cells, T cells. Effective vaccination, does it work? Do we see an increase in antibody levels? And sometimes you can already tell from the past, did it work or did it not work? Because most of the kids get vaccinations when they are very young in their regional or national vaccination campaigns. And sometimes you have encountered maybe very severe adverse reactions, which could already be a sign of an immune deficiency. So also medical history, very important. How did these kids react to previous vaccinations? Did we have tests at that time that showed already that these vaccines were not effective? So also history taking very important, and also you can think about, hey, what did happen around these vaccinations in the past? And B cell tests, memory B cells, it's not available in all regional hospitals, which should be considered as an additional test. So these are very important tests to do. And then what can we do? Because I already told you, it is a genetic defect. It is part of Jacobson syndrome or 11q disorder. So we cannot solve this problem. So we cannot make the immune system work better. We cannot make the immune cells start producing more antibodies. So we cannot solve the problem. We can only prevent complications caused by these problems. So it's only 3 things actually we can do if you have an antibody deficiency. And it's not only for patients with Jacobson syndrome, but for all the patients that I see in general with antibody deficiency, these are the 3 options. 1, and it's very obvious, of course, if you have a serious infection, you have to start antibiotics straight away. If you think about a bacterial infection, you should not wait a few days, start antibiotics. In case of very severe or recurrent infections, so if we have recurrent infections over time caused by bacteria, we sometimes prescribe prophylactic antibiotics. So every day or every other day antibiotic to prevent recurrence of infections. And the third is to give antibodies. Because if you have low levels of antibodies or your antibodies do not work as they should, we can give them by subcutaneous or intravenous infusions. We can provide those patients with antibodies collected from healthy blood donors. So these are the 3 treatment options we can and should consider in patients with antibody deficiency, including patients with 11q disorders. So I think it's really clear until now that patients with 11q disorder have an increased risk of infections, particularly caused by antibody deficiency. we should test for it, and we should treat accordingly. But then the question, is that all there is? Because the antibody deficiency did not explain the warts in my patient, because warts are not depending on antibodies, but we need T cells to clear the virus. So it's all a nice story, but still I haven't explained the problems with this guy with these clear warts. So the question is there more in Jacobs syndrome? So Elise Huisman, she's actually a hematologist in training, who was also working on the Paris-Trousseau syndrome, but she also found some interest to evaluate in more detail the immune system. And she invited, in this case, 14 patients from the Netherlands with an 11q disorder, with different genetic profiles. And she said, well, maybe we can look for more defects, because yes, we showed already there is a problem in the B cell, but the question is there also a problem in the T cell? Because these warts or viral infections are also a problem. And this is an elaborate table, but just really important to show. 14 patients were included, and if you look at the tests that we did, we evaluated T cell function, because also T cell numbers over here can be low in a number. In the half of the patients, the T cell number is normal. So again, measuring T cells, yes, it's interesting, but not explaining everything. And you see that indeed in all but one, T cell function is low. And that gives an increased risk of viral infections and fungal infections. What can you do about T cell defects? Unfortunately, not so much. Again, you cannot correct the T cell function. It gives rise to an increased risk of viral infections, fungal infections. The only thing you can do is treat accordingly. Give antifungal treatment, antiviral treatment when necessary, or sometimes also prophylactic antiviral treatment to prevent infections. But again, the treatments are all symptomatic. We cannot solve this issue. So we see B cell problems, T cell problems, we see bacterial infections, viral infections, and one of the major questions, of course, why? Why is this in Jacobson or 11q disorders? Why is there immunodeficiency? If we look at chromosome 11, we know that there are 6 genes on chromosome 11 that are all involved in immune cell development. Of course, immune cells arise from the bone marrow, from stem cells, and there are all different mechanisms of action that need to occur before you have normal B cells, before you have normal T cells, before you have normal neutrophils, etc. And there are 6 genes, resulting in proteins that are involved in this process that are on chromosome 11, and that may be affected if you have the deletion of a part of chromosome 11. These genes may be deleted as well, or may be damaged, and that may result into immunological problems. I have to admit, we don't know which one of these genes, or combination of genes, or one gene is responsible for the immunological defect. There are some interesting findings over the past years, and for instance, this is an interesting finding a few years ago. In 2022, there were 3 patients with Jacobs syndrome, and they all had missing of the ETF1 gene, and that was related or associated with the immune deficiency, while the other genes mentioned on the list of 6 were all present and normally functioning. So there are some suggestions, but it's very speculative at this moment, that related to the immune problem is the ETS gene that is involved. So to conclude about the immunodeficiency, what do we see? I think a large number of patients with Jacobs syndrome suffer from infections, that was already known, low antibodies, that's I think a particular problem, caused by low numbers of memory B cells, defective immune memory. And this is related to the infections that we find, and I think that all patients with 11q disorder require immunological screening. Because, as already said, and it's not my personal opinion, it is, I think, generally recognized by immunologists worldwide, that the majority of 11q patients have an immunological defect. So I think it should be included in the screening. And of course, if you find it, you have to treat it accordingly. And again, remember, because I want you to tell your doctor, numbers don't tell you all. So if you get a test, immunoglobulins are normal, B and T cells are normal, so you don't have an immunodeficiency, don't believe. It can be true, of course, because sometimes if normal levels are there is no immunodeficiency, but you should look in more detail. Functional defects. Do these antibodies do what they need to do? Do these T cells do what they need to do? So just basic testing doesn't explain it all. So if you get a nice overview with normal results, try to be critic, because if you still see infections in your kids, then you should look in more detail. Functional tests, really very important. And I put it here, sometimes we don't find anything. So we do B cell testing, normal, antibody testing, normal, vaccination testing, normal. We don't find an immunodeficiency. And still, the kids suffer from recurrent bacterial infections of the lungs. Then I can say, well, again, paperwork, even in additional testing, we didn't find anything. So the answer is there's no immunodeficiency. But I don't know whether that's really true. Because we also have to admit that we know a lot about the immune system, but we don't know everything. So it would still be something that we cannot evaluate yet, that we don't know yet. So also, if everything is normal, but there are still infections, I think we should consider an immunodeficiency without a proof of that, because some of the things that are important in the immune system we don't know yet, or we cannot test for it. So also discuss it with your doctor what to do, because sometimes you can start immunoglobulin replacement therapy as a proof to see whether that improves the clinical condition. Also, if you find nothing. So very briefly, immunizations, because these kids have severe infections, frequent infections, and one of the ways to prevent infections, of course, immunization. And we know this, of course, from the COVID pandemic, and we were studying worldwide what kind of effect did these COVID-19 vaccines have in patients with immunodeficiencies. And ourselves, we did a large study in the Netherlands. It was one of the largest studies in the world on the effect of COVID vaccination in patients with primary immunodeficiencies. So not particularly Jacobson syndrome or 11q disorder, but immunodeficiencies in general. And we've always thought, well, these vaccinations, they don't help, because these patients do not build up memory. They cannot produce antibodies after vaccination. They cannot produce B cells after vaccination. So why should we do vaccination? Very important. New vaccinations against COVID-19 were developed based on new platforms. You may have heard of the mRNA-based vaccines, of course. And also here, just do not look at the numbers, but what we see, these were the controls, and on the right side, patients with antibody deficiencies that has most of them had a good response after vaccination. So we always believe that these patients would not benefit from vaccination, because what we expected is that they were all here. No formation of antibodies after vaccination. Yes, the boys, remember, those who could not produce antibodies, they do not after vaccination, whatever vaccination you give. But the majority of the patients we see, and I think that also should be true for a patient with 11q disorder, are able to produce antibodies after mRNA vaccines. So I think with these results, we show that mRNA vaccines are more effective in patients with antibody deficiencies. Also, we look at T cell responses, but also more or less comparable to healthy controls. So these could be very helpful in the future to prevent infections in patients with these immunodeficiencies. So vaccinations, we always thought, doesn't work, doesn't help, but I think with the development of new vaccine platforms, also people with immunodeficiencies, including 11q disorders, might benefit from vaccines in the future. So again, vaccination, yes, can be something for the future. I also have to admit, Is it enough? Because vaccination, we see increase of antibodies. That's what I just showed. But again, what does it say about antibody function? Because you can see an increase in formation of antibodies, but if they do not function well, then you still might not be immunized. You may not be protected against infections. In these studies, we showed that also after vaccination, patients didn't get the severe disease as they had before, so it seems also be prevented. So really briefly, we were talking about infections, but you remember the balance in the immune system. So on the one hand, you have immune deficiency, but on the other hand, you have also autoimmune disease. So if you have a problem in the immune system, you may have infections, but some of the people with immune deficiency also have more other complications. For instance, for skin, joints, or others, because of autoimmune disease. And actually, little is known about that. And I was asked about Lindsay, do you see these kind of problems in patients with Jacobson? So not only the infections caused by immune deficiency, but most of these patients do not have an immune deficiency, maybe only, can also be immune dysregulation, including autoimmune disease. And particularly what's interesting, and I tried to read about it a bit in literature, but little is known about the autoimmune conditions. Do we see an increased number of autoimmune conditions? Because in the patients that I see generally, patients with primary immunodeficiencies in general, a lot of those patients not only suffer from infections, but also suffer from autoimmune conditions. Around 20% of the patients I see also has autoimmune phenotype. But in Jacobson syndrome, actually nothing is described, nothing is known. But I think what we see, and I was discussing with a hematologist because she's a pediatrician, sees a number of these patients. For instance, eczema, atopic dermatitis, psoriasis, vitiligo. A number of these patients that we saw in the Netherlands have these skin conditions. It can be, of course, just bad luck, whereas eczema is very common in the general population. But in people with immune deficiencies, immune dysregulation, and I wouldn't say that could be bad luck. We think it should be a relation between this immune dysregulation and skin conditions. And also for joint conditions, rheumatoid arthritis, autoimmune disease. Is it something that we see more often in 11q disorders? I have to admit, I don't know. But I think it's very interesting to get more details about not only the infections, but also about autoimmune conditions or other immune dysregulation conditions where these occur more frequently in Jacobson. But that's really a field of investigation, I would say, to better understand maybe the late complications, because these are typically not symptoms that occur in early childhood, but typically evolve over time. So I think we should definitely collect more data to see where this is truly something. But I think there are some signs indeed, and maybe something that you recognize, that also skin conditions, not infectious skin disease complications, but also other skin related issues may develop in this disease. So with that, I will end my presentation, and I hope to have given a short but brief compact overview of the immune system, and also things to think about from your side, to discuss with your doctor, to show them what they need to test. Be nice, of course, but you have to, you really can ask for it, because I think it is an issue. It's an important issue because many of the people suffer from these infections. And if you don't think of it, you won't test for it, and you will never know. Thank you.
Thank you, Virgil. I have one quick question. Peter had walking pneumonia and bronchitis within a really short time over the last couple of months. Do you think he should get the pneumococcal? Is that even the right name? Vaccination? Would you recommend, like, he's only 20, but do you think that's?
Yep. Yeah, so the question, so he had suffered from pneumococcal disease or pneumonias?
Well, it was walking pneumonia.
Okay, yeah. Yeah, so I think in general, of course, there are all different kind of national programs available, but I think in people with immunodeficiency, and I would consider if you have or if you have not tested anyway, people with Jacobson syndrome are immunocompromised, so they should be vaccinated with, and then preferably not Primovax, but one of the newer vaccines,
Okay,
because that's a more technical story. So if you give Primovax vaccination, you target the B cells to produce antibodies only. And most of the people suffer from a problem in this B cell formation. So if you give Primovax, most of the cases it's useless because it will not prevent you from disease. You have to use, I don't know what you have in the different countries, but it's the polysaccharide protein conjugate vaccine, so it's Prevnar mostly used. And Prevnar stimulates both T and B cells.
thank you.
I had one quick question. I know with other genetic conditions like 22q and IPAX, like you can have the newborn screening flag for like a skid
Yeah.
picture. And so sometimes I get like families are like, oh, do they also have that? I'm like, no, it's just the way that the screening works. Can you see that in Jacobson syndrome?
Yeah.
Is it out?
It's an interesting question because so in the newborn screening, we have indeed implemented SCID, this severe combined immunodeficiency. So those are children that have no or almost no B and well, most particularly no T cells. So when the kids get born, they get this newborn screening, and you evaluate for T and B cell numbers. And in the past 5 years, we have detected 2 kids on newborn screening with low numbers of T cells. And these were referred to the pediatric hospital and were found to have Jacobson syndrome. Yeah, so in those ones that you find these low numbers of T cells, you could be able to find them. Yeah.
Great. Well, first of all, I think you get the award for the best special effects. Those are awesome. Not to understate this, what Virgil and Ken Paris, who couldn't make it to this conference, have accomplished has had a huge impact. And literally, this knowledge has led to life-saving interventions. And as what was alluded to, this whole story started when they started doing screening of newborns for the severe combined immunodeficiency. And then at that same time, I learned of at least one child with Jacobson syndrome that died from RSV virus. So it all kind of came together. And again, kudos to you and Ken for your participation in this and for advancing the knowledge. Couple other comments. I think the point that you make about it's not just about the number, but also function is huge. And as I'll talk about tomorrow for Paris Trousseau, same exact concept for platelets. And so if there's nothing else that you guys take away from this conference, is like what Virgil said, you have to teach your treating physicians, because I can tell you, I see this all the time. People just are dismissive if they see that the number is normal. Lastly, I wanted to bring up an issue that relates to your last point about autoimmune disease in Jacobson syndrome. There are at least 2 young men that I know of that have suffered complete alopecia, complete hair loss. And I'd like to hear your thoughts about how that is probably a reflection and what maybe to do about it.
Yeah, so that's indeed, actually, I hadn't thought about it at all until Lindsay sent me the email, maybe you can touch upon, and then it was a lot of homework, and actually there's not much known. But if I make a comparison with people with other kinds of immunodeficiencies, so the patient that I regularly see, yeah, like I said, around 20% of these patients suffer from autoimmune conditions. So that it's because we're talking about immunodeficiency, and actually that term is not so much in use anymore, because immunodeficiency suggests there is loss of immune cell function with infections. And nowadays it's more called inborn errors of immunity, because the majority of these patients, or at least 20% of these patients, not only have infection, but also have autoimmune conditions. So I think indeed eczema, atopic dermatitis, but also of course alopecia. Alopecia is a typical autoimmune condition. So yes, you could say it is bad luck that you have N. Jacobson syndrome and alopecia, but I think it should have been something that is indeed related due to the immune disorder. The immune disorder can either cause immunodeficiency or autoimmunity, or both in the same, because that's also something that I still do not really understand, because in 20% of patients we see an immunodeficiency and autoimmunity. Why? Because you say, well, the immune system isn't working well, but it may cause autoimmunity. So it is a completely disbalance. And I think it's really interesting to to look in more detail if we can collect data. Is it indeed something that is commonly seen? And then the question is, of course, what do you do with it? Because if you have alopecia or any other autoimmune condition, you tend to start with immunosuppressants. And if you give immunosuppressive medication, and definitely on this side, you will go down even more. For instance, prednisone, just as an example of immunosuppressants, prednisone lowers your antibody levels. So if you start treating autoimmune problems, you create more infections. So that's very difficult how to balance that treatment then.
Also been well described if you can down.
Yeah. Yeah, exactly. Yeah, so also in Down syndrome, of course, it's different genetic underlying defect, but also there, autoimmunity and immunodeficiency, because not the majority, but I think around 30 to 40% of patients with Down syndrome has an antibody deficiency. Yeah, and also there, it wasn't recognized for many years because it was thought, well, these kids, these have their mental psychomotor retardation, they have difficulty swallowing, they tend to end up with food in their lungs, and then they get pneumonia. No, it's not the case. It was an immune defect. Yeah. So also here, there is and a genetic defect, and an immunodeficiency, and autoimmunity.
Will there be any correlation between keloids and those types of things?
Yeah, question of course is why keloids develop. It is I would say an overactive response to, let's say usual harm, because mostly it's something, it can be very very simple and then result in keloid formation. Does it have to do with the immune system? Yes, I think because if you form scars, because keloid is of course something like a scar formation, macrophages, so these eating cells, those come into play because these are very important in scar formation. You could propose that if these become also overactive and an immune dysregulation, that difficult or complicated scar formation resulting in keloids may occur. But it's really speculative, but thinking about this concept, that could be. Sorry.
Okay. So my daughter's just 2. Since 6 months old, she has suffered from recurrent UTI infections. She does have a severe component deficiency. She receives sub-Q infusions. The problem we're starting to run into now is prophylactics are no longer working either. She's starting to grow truly resistant bacteria, so she's bouncing between 2 or 3 different antibiotics, but she's only getting like 5 days between infections before a different bacteria is taking over. And so it's this game. Our immunologist is great, our urologist is great, our nephrologist is great, but all 3 of them seem to be getting to kind of this stand still, we don't know what to do point. Do you have any recommendations from the immune system stance that might help, or that someone may not have thought of yet?
Yeah, so that's a very complicated situation, of course, like you, because you get immunoglobulin replacement therapy, you get prophylactic antibiotics, they will treat with antibiotics in case of infection. So if you see, well, like I told, what can we do in relation to antibody deficiency, every step has been taken here. And also, it's something that is unfortunately occurring is antibiotic resistance, like you mentioned. Normally, we don't see that too often in patients with antibody deficiencies, but here it seems to happen. Then the only what you can do is change the antibiotics over and over in time, and to see whether you get rid of this resistant bacteria and select non-resistant bacteria, so to say. But it's, I think, like you present now, it's very difficult. And what else could you offer? Consider vaccination when she is a bit older, just to boost the immune system a bit. But like you said, it's a combined immunodeficiency, both B and T cells. It will be a challenge indeed. Yeah, so I think maybe increasing dosage of immunoglobulins. No way that has been tried, because that can sometimes, because we tend to base our dosing on body weight. Sometimes we can even give more to prevent infections. Keep changing the antibiotic regimens, maybe vaccination, prophylactic antivirals, but I don't know whether that is the issue. Viral infections, not so much. But I think those are the things that you could maybe discuss.
Real quick, before we go on to the, before we go on to the next, we're gonna continue questions, but if you have kids in the childcare, grab them, because the childcare providers need to go to lunch.
There's one more question.
We still have several questions. We're just gonna keep going with questions. I just want the childcare providers to go to lunch.
Just real quickly, do you see relationships between the immune system and the endocrine system? I ask that because Sydney was diagnosed with, I think it's called virotism. She had hair growth, and I hear about alopecia, hair loss. She has the opposite issue, which is excessive hair growth. And I'm just wondering if there's a relationship between those two systems.
Yeah, definitely. So, I may not have too much time, according to Lindsay, but there is
keep
a
going.
lot of interaction between the immune system and the endocrine system. So, for instance, also here, we did a study ourselves a few years ago, because we noticed that a lot of patients with immune deficiencies, not specifically 11q related, but immune deficiencies, a significant number of those suffered from endocrine dysfunction. And it could be everything. It could be thyroid dysfunction, diabetes, could be adrenal dysfunction, problems with testosterone in men, for instance. So there are a lot of endocrine disorders described in patients with immune deficiencies. So we see it in this group of patients, the relation. But we know also that there is a huge interaction between the immune and endocrine system in general. Yeah, so the question is, of course, if you have an endocrine dysfunction, is it due to immune dysfunction targeting the endocrine system, or is it solely the endocrine system? That we don't know. It can be either way, I think. But yes, there is a lot of interaction between those systems.
I have a quick question. So my daughter is 6, and we had a screening done when she was 2 that showed some concerns. But obviously they said like her numbers are okay, so don't worry too much. But you said that this can't improve, like things can't be fixed. Is this like a type of screening that you continue to get as you get older because things can improve, or is it like the one screen you get, these are your numbers, this is?
Yeah. It's good that you mentioned this, because Ken always tells me that I have to present it, and I forgot to put it in the on the PowerPoint indeed, because you have to repeat it. Because I think that if you have an immune deficiency and you find an immune deficiency by numbers or lab results, that it will not improve over time. So once you have an immune deficiency, have to be a bit careful, depending on the age that you do the testing, because we know that if you are born, your antibodies are low, because you do not produce antibodies yourself. You get the antibodies from the mother, and the first months you live on the antibodies of the mother, and then gradually the immune system starts growing. You start producing your antibodies. So if you do the testing too early, then you may find something that may recover over time. So we generally say, if you start testing the immune system, start after the age of 4, because then you are evaluating the final version of the immune system. Because otherwise, if you are too early, you will find defects, but those are not defects, it's just the immune system has to evolve. So, but if you find something that's not normal, then I think you would conclude it will not become normal anymore. But with this disclaimer, depending on the timing of the test. On the other hand, if you find normal tests, what we know, that we also know from general primary immunodeficiencies, that sometimes you don't find any absent antibodies, you don't find any dysfunctional tests. But if you repeat it a few years later, then you will find something. So it is also something that may be progressive over time. So if you have still infections, if you have still the gut feeling there is something wrong in the immune system, you should definitely do retesting over and over time. Why? Because it's something that may develop, and also the tests are getting better. Because what I'm showing you now, some of these functional tests you couldn't do 10 years ago or 15 years ago. So then we didn't do the functional tests, and then we said, based on the numbers, it's normal. But now if you test it in more detail, you will find it. So if something is found to be normal, but you still have the thought there should be something wrong, we should do repeated testing over time. Also, what we know, when we are aging, unfortunately, but also our immune system is aging. So what we see that over time, our immune system gets worse, so to say. That's why we see an increase, especially in people over 65, an increase in the number of pneumococcal infections. After 65, we see an increase in a recurrence of viral infections. Think of herpes zoster. That's why we implemented vaccination strategies for Shingrix, herpes zoster vaccination, because our immune system is aging. And in patients with immunodeficiencies, I don't know for Jacobson because it has never been studied because numbers are low. But if we look in the general population, if we look at patients with immunodeficiencies, I would say also in Jacobson, also this aging occurs. And then if you are already on the lowish side, then this decline may become more evident over time. So that's another argument of do repeated testing because of natural occurrence of progressive disease, but also progression due to aging.
How often should you repeat it?
Difficult to say it's every so and so, but I think if you really have the clinical suspicion, we advise you to do every 4 to 5 years. But that may differ from country to country, of course. That is reasonable because to repeat it every year, chance of finding something is really low.
Thank you.
Any more?
Right.
Did we get them all?
Right.
All in question?